Pelvic inflammatory disease. Pelvic inflammatory disease is common and often asymptomatic problem in young women. It's a major cause of morbidity in young women, although its incidence in the primary and secondary care is decreasing over the several years, but still its consequences are serious and we need to diagnose and treat it as early as possible. So if we start with who gets pelvic inflammatory disease. The risk factors for pelvic inflammatory disease are strongly related to sexual behavior and most likely with sexual transmitted infection, young age, multiple sexual partners, lack of condom use, lower socioeconomic status. However, it is still uncertain why certain women are more susceptible to infection than others. There are some factors which help, like cervical mucus. It was found that cervical mucus acts as a plug, which prevents the ascending of infection from the lower genital tract to the upper genital tract. And it was found that in anovulatory women, this cervical mucus plug is thin, and accordingly this barrier mechanism is deficient, which facilitates infection of the upper genital tract. Part of that as well is immunity, and it was found that there is an increased risk of pelvic inflammatory disease in women with human leukocyte antigen subtype A31, while women with other subtypes like human leukocytic antigen DQA 0501 or DQP are a bit protected or lower rates of infertility following a diagnosis of pelvic inflammatory disease. There was a clear association can be seen between the vaginal douching and pelvic inflammatory disease. However, more recent studies suggest that vaginal douching doesn't cause PID, rather than it would appear that vaginal discharge and the menstrual irregularity, which is common with pelvic inflammatory disease, themselves may lead to more douching. It's found that as well that women who smoke are at higher risk of pelvic inflammatory disease, but it's unclear what is the mechanism for that. So the most common cause of organisms of pelvic inflammatory disease are Neisseria gonorrhea, chlamydia, and anaerobes. That's why the treatment of pelvic inflammatory disease we choose the antibiotics which are mainly against these types of bacteria. Other causes like actinomycosis, which is common especially in patients with intrauterine device. And here comes a controversy whether or not to remove the IUD. It was found that if there are no symptoms of discharge or bleeding or pelvic pain, then the woman should be advised that neither treatment nor removal of IUD is required, but this woman should be reviewed in 6 months' time or earlier if any symptoms happen. However, on the other side, if the patient has any symptoms, then at least she required 2 weeks therapy of penicillin, tetracycline, or macrolide antibiotics, and the IUD should be removed. What's the clinical presentation of a patient with pelvic inflammatory disease? The most common presentation is pain, usually lower abdominal pain, bilateral, associated with adnexal tenderness or cervical excitation on vaginal examination. And here it's very important to take proper history and examination, including accurate menstrual and sexual history, because this will help you to reach a diagnosis. Definitely pelvic examination is essential with speculum examination and swab. Other features: intermenstrual or postcoital bleeding, deep dyspareunia, abnormal discharge, fever which is non-specific, nausea and vomiting may occur in severe pelvic inflammatory disease. It was found that pelvic inflammatory disease, which is caused by gonorrhea, has a more acute presentation and more severe than what's caused by chlamydia. For diagnosis of pelvic inflammatory disease, we have an essential features and supporting features. So the essential features, as we said, is the lower abdominal pain, adnexal tenderness, and cervical motion tenderness. But supporting features will be the intermenstrual bleeding, postcoital bleeding, vaginal discharge, deep dyspareunia, fever, right upper quadrant pain, or generalized peritonitis. Special circumstances are a woman with HIV. These women are at high risk for pelvic inflammatory disease, as well as high risk of more severe PID, as well as its complication. And these women should be screened for other sexual transmitted infection as well. Intrauterine device, and we explain its association with actinomycosis and the management for it in the previous slides. And the last circumstances is adhesions, which is usually found between the liver and the abdominal wall, which is fine filmy as shown in the picture. We found it common in patients with pelvic inflammatory disease. And if you find it and it's easy to divide it, it's recommended to divide these adhesions. So what's the complication of pelvic inflammatory disease? Actually, I found a nice mnemonic for it, which is I face PID. So I stand for infertility, F stand for Fitzhugh-Curtis syndrome, A abscess, C chronic pain, E ectopic pregnancy, P peritonitis, I intestinal obstruction, and D disseminated infection. So how to diagnose pelvic inflammatory disease? What is the systematic way to get a diagnosis for pelvic inflammatory disease? First, it's the clinical presentation, which highlights the suspicious, and as we said before, pain, bleeding, discharge. However, I always emphasize that you have to do a pregnancy test for any woman in the childbearing period who present with bleeding or pain to exclude pregnancy. And the most important differential diagnosis, which is ectopic pregnancy. That's why pregnancy test is the first step to be done. Then, if the clinical picture is highly suspicious, we have to do a chlamydia and gonorrhea nucleic acid amplification test, which is through a vulvovaginal swab. And if it is positive and the patient is at high risk for sexual transmitted infection, in this case we have to offer endocervical swab for gonorrhea culture, nucleic acid amplification test for trichomonas vaginalis, HIV antibody test, and syphilis serology if it is prevalent or endemic in the area. Endocervical swab for Neisseria gonorrhea culture should be placed in transport medium and arrive at the laboratory preferably within 6 hours, but certainly within 24 hours, otherwise the viability is rapidly lost. If it is suspected at laparoscopy or laparotomy, then a specimen from the fallopian tube should be sent, definitely if it is indicated. And if the specimen of the fallopian tube was sent, it should be request bacterial culture, including gonorrhea, chlamydia, as the nucleic acid amplification tests are not licensed for the use of fallopian tube, and therefore it requires cautious interpretation. If we go for a radiological investigation, a transvaginal ultrasound may be useful. However, there is no features which are pathognomonic of pelvic inflammatory disease. Common feature is free fluid in Douglas pouch. It's a common finding. However, it can be common in normal. So really the value of the ultrasound is to exclude other causes like ectopic pregnancy, ovarian cyst, appendicitis. It sometimes can point at tube ovarian abscess or a dilated fallopian tube, which can a bit confirm the diagnosis of pelvic inflammatory disease. However, we shouldn't rely on the ultrasound for that diagnosis. MRI can help, but is not widely used. CT scan can show obscuring of the pelvic fascia planes, thickening of the uterosacral ligament, or accumulation of fluid in the tube or endometrial canal. It can be also diagnostic in the upper abdomen of the perihepatitis adhesion. However, it is not used as a routine investigation. So differential diagnosis of PID include ectopic, and here comes the importance of pregnancy tests. That's why we emphasize that any woman in childbearing period should have pregnancy test first to exclude ectopic. Appendicitis is second common differential diagnosis. Patient will present with right side iliac fossa pain, vomiting, nausea, high fever. It can be confusing with PID. Complicated ovarian cyst, again, it can present with abdominal pain, and other manifestation of peritonitic irritation, which give very similar picture. Endometriosis, urinary tract infection, and functional pain. The ultrasound can help in excluding some of these differential diagnoses. For example, if you have an ultrasound and it shows an ovarian cyst, so this pain is most likely as a complication of cyst, or an ovarian torsion, which is the more severe and more serious. Hemorrhagic cyst of endometriosis can be easily visible by ultrasound. Urinary tract infection will appear by urine analysis, which will show nitrites or leukocytes, which indicate of infection, and usually by antibiotic it will resolve the pain. So for management, is it outpatient or inpatient? Usually the management of pelvic inflammatory disease is an outpatient management, except if you cannot exclude surgical emergency or lack of response to oral therapy or clinically severe disease or intolerance to oral therapy, pregnancy, or in case of tubal ovarian abscess, where this patient will need close observation and you will need inpatient management. We need to provide patient with general advice is to provide rest, analgesics, proper counseling, and avoid unprotected sexual intercourse. And if the patient is high risk of sexual transmitted infection or proven to be positive for sexual transmitted infection, we need to provide screening for his partner. Intravenous therapy will depend on the severity of her condition. So this is the protocol we use for management of these patients. So we have an outpatient management, which we start with intramuscular dose of ceftriaxone, 500 mg single dose, followed by doxycycline 100 mg twice daily, and metronidazole 400 twice daily for 14 days. Oral ofloxacillin 400 twice daily, plus oral metronidazole 400 twice daily for 14 days. This is the other regimen. Or intramuscular ceftriaxone 500 mg immediately, followed by azithromycin 1 gram per week for 2 weeks. Or oral moxifloxacillin 400 mg once daily for 14 days. Different choices will depend on the patient profile, like allergy, most sexual infection, whether gonorrhea is prevalent or chlamydia. So I discussed now the inpatient therapy, and the inpatient therapy, as we said before, it's mainly for severe cases or if surgical emergency is suspected or lack of response to oral therapy. And with inpatient, we start with intravenous antibiotics. It should be started as soon as possible, and the recommended regime is intravenous ceftriaxone 2 gram daily, plus intravenous doxycycline 100 mg twice daily. We continue for the IV for at least 24 hours after clinical improvement, then we switch to oral, and the oral will be doxycycline 100 mg twice daily, plus oral metronidazole 400 mg twice daily for a total of 14 days. Regimen number 2 is clindamycin, and it's used as 900 mg 3 times daily, plus IV gentamicin 2 mg per kilogram loading dose, followed by 1.5 mg per kilogram 3 times daily. IV ofloxacillin 400 mg twice daily, plus IV metronidazole 500 mg TDS for 14 days. And as I said, parenteral therapy should be continued until 24 hours after clinical improvement, and oral therapy to continue to complete 14 days of antibiotics in total. Some few points about the choice of antibiotics. We know that gonococcal is highly resistant to ofloxacillin and moxifloxacillin. That's why we need to avoid them in patients who are at high risk of gonococcal PID. Also, quinolone should be avoided as a first line of empirical antibiotic treatment in areas where gonorrhea is more prevalent. Levofloxacin is an early isomer of ofloxacillin and has the advantage of once daily dose, so you can give it as 500 mg once daily for 14 days. It may be used as a more convenient alternative to ofloxacillin, so we can use it. So now we go for the surgical treatment. And what is the indication for surgical treatment? Surgical intervention is rarely required. This we have to highlight that. It's rarely required as a treatment for acute PID. Most patients usually present early enough for antibiotics to be fully effective. However, there are certain indications for laparoscopy or laparotomy to drain a pelvic abscess if diagnosed by an ultrasound, and doesn't appear to be resolving with conservative antibiotic therapy. From my personal experience, we give antibiotics for about 2 to 3 days, and if the antibiotics after 3 days the patient is still feverish, still not responding well, then surgery will be indicated because there's a pus, and this pus needs drainage. We know that any abscess needs drainage in order to resolve. There was other American studies which show that any abscess which is more than 8 cm antibiotics will not be effective, and surgery should be started at once. However, still, we feel that a period of antibiotics of 2 to 3 days initially can be effective. That's why this is usually the initial management. If the patient presents stable and the pain is under control, we can give her the trial of antibiotics empirical for 2 to 3 days and review. But if no response, then laparoscopy will be indicated. And I always advise that during a laparoscopy or laparotomy, do the minimum required because the tissue at the time of infection is friable. So bleeding and tearing can be quite common and often. That's why do the minimum required. Don't be tempted to do extensive surgery at time of infection because healing will not be good as well. So drainage will be enough. As long as you do drainage and good washing, it will be enough. If you have some adhesions, you can divide to release the pain. But again, it's the minimum required to treat. Follow-up. The initial follow-up will be after 72 hours to be sure that the patient is responding. This is particularly in outpatient management. So if you give a patient outpatient management as an antibiotics, you will see her after 3 days, discuss how she feels, is there any indication for inpatient, is she responding well to therapy, and then after 2 to 4 weeks. However, in case of inpatient management, she's already inpatient, she will stay in hospital. She will continue for IV for 24 hours of clinical improvement, then oral antibiotics, then we'll see her again after 72 hours after discharge to be sure that she's okay. Sometimes the role of virtual clinics when we can give her a call, ask about symptoms, and save her a visit to the hospital if it's applicable. We need to enforce the advice about the sexual transmitted infection, about future condom use, about how to prevent further infection again. We need to highlight the prognosis of that, like chronic pelvic pain, subfertility, ectopic pregnancy. All of these need to be highlighted and we need to be aware about it. We all know that intrauterine device increase the risk of developing PID, especially in the first few weeks after insertion. However, there is no evidence of increasing risk of continued use of an IUCD. Thank you.